Assalamu alaikum. The Lund Clinical Consultation Day. First scenario, Sarah Smith, 36-year-old lady, presented with hemoptysis. The observation, blood pressure 120/80, heart rate 90, respiratory rate 19, saturation 95 on room air. Take history and examine the patient. Ready, Dr. Hani? Hello, Dr. Hani, ready? Dr. Hani? Can you unmute yourself, please? Dr. Inas, you can hear me?
Yes.
Dr. Hani, you ready?
Yes.
Okay, you can start. Here you go.
Okay. Hello there. Hello.
Oh, hello.
I am Dr. Hafiz, the doctor in the clinic today. Can I confirm that I'm talking to Sarah Smith?
Yes.
And you are 36 years old?
Yes.
Nice to meet you, Mrs. Sarah.
Nice
Miss
to
Sarah,
meet
I am
you.
here today to discuss your health condition. So I will ask you some questions. And after that, I will examine you and address your concerns. Is that okay with you?
Yes.
Okay. So before we start, can you tell me what brought you in hospital today?
I've been coughing blood for the last 24 hours.
Okay. I am sorry for your suffering, and I will try to do my best to help you today. So, can I ask you when this started exactly? Just 24 hours?
Yeah, just last night. Yeah.
Okay, and this is the first time or the current?
No, first time.
Okay. This happened suddenly or gradually?
No, suddenly. Yeah.
Okay. And now increasing or decreasing was the same?
Kind of the same.
Okay. So how much is the amount of this blood?
I think good amount, maybe 10, 15 ml. Fresh blood, no clots.
Okay. So 10 to 15 milli only.
Yeah.
And this happened once.
No, more than 5, 6 times in the last 24 hours.
6 times. Okay. So any cough before this coughing with blood happened
No,
before that?
no,
No cough before.
no.
Okay. And the blood was fresh. Am I right?
Yeah, I think so. It looks like bright red.
Do you notice anything increase this coughing of blood with you?
Pardon?
Do you notice anything increases this with you or aggravating this?
No,
Do you notice anything improve this coughing of
no,
blood? Okay. Any chest pain?
no, not really.
Okay. Any shortness of breath?
I'm a bit short of breath, yes.
Okay. Since when? Since when this happened? Just shortness of breath?
The same time, like in the last 24 hours.
Not before that.
No,
Okay. So any runny nose?
no,
Any nasal bleeding?
no,
Any leg swelling?
no.
Any racing of your heartbeats?
Palpitations, no.
Okay. Any high body temperature?
No,
Okay. Any lumps or bumps in your body?
no,
Okay. Any change in your appetite? Any loss of
sorry?
appetite? Sorry,
Sorry, I didn't hear you.
there is lots of type.
No.
Sorry, I can't hear you. Can you raise your voice a bit?
No, I said no.
Okay. Any feeling tired?
No, really, I'm right.
Okay. Any lump in your neck?
No,
Okay. Any headache?
no,
Any loss of consciousness?
no,
Any visual problem? Any vision
no.
problem? Okay. Any problem in sensation in your limbs or your body?
Any problem in
Sensation.
sensation? No, no,
Needles or not? Okay.
no,
Any weakness in your body or your limbs?
no. I just feel like fatigued, maybe, but no significant weakness.
Okay. Okay. Any mouth sores?
No,
Okay. Any tummy pain?
no tummy pain. No,
Okay. Any heartburn?
no,
Any tummy swelling?
no,
Any feeling sick or getting sick?
no,
Any change in your bowel habits?
no,
Any oral discoloration of your eye
no.
or skin? Any change in your water work?
I usually have like urine infection is every now and then, but not on this occasion.
Urine infection? Sorry.
Yes, I have some urine infection, urine tract infection every now and then, but not on this occasion.
Okay. Is this now or before
No,
recurrent?
before, in the past, I've had multiple UTIs.
And now you have any problem in your water work now?
No,
Okay. Any change in the color of your water work?
you mean the
Any
urine?
blood?
No,
Any blood?
no blood, no.
Okay. Any foamy urine?
Frothy, no.
Mm, okay. Okay. So any bleeding from any body orifices
No, not any other bleeding, no.
or under the skin?
No,
Do you feel you became pale or any body tell you that you are became pale?
no,
Okay. Any skin rash?
no,
Any joint pain?
no,
Any skin changes?
no.
Okay. Do you have any past history I should be aware of? Any
I have
long-standing
diabetes
since when?
since I was 16.
And what's the medication you are taking?
I'm on insulin.
Okay. And how much is the dose?
I take like Lantus 12 units in the morning, and I take Novorapid 5 to 7 units with meals.
And is it controlled?
I'm not sure. I don't know.
What's the last accumulated blood sugar?
It was
HbA1c?
14. Accumulated HbA1c.
Yes. Yes.
It was 60.
60.
Yeah, I'm not sure what's the numbers elsewhere, but in the UK, 60 is too high.
Okay. So, okay. Any other disease?
No,
Okay. Any past history of any surgical operation or procedure?
I've had fibroid surgery removed. I've had a scar in my private area. They've had fibroids removed. Yeah.
Since when?
Sorry?
When this happened?
6
When
years
this
ago.
happened?
6 years ago.
6. Okay. Any history of any blood transfusion?
No.
Okay. Any tattooing or piercing?
No.
Okay. What's your medication list?
I am just on insulin and I am on ramipril for high blood pressure.
You also hypertensive.
Yes.
Since when?
In the last 3 years.
Is it controlled?
I would say so, yeah. My readings
Oh,
is like 130, 135.
okay. Any herbal medication or over-counter
No.
medication? Okay. I'm sorry for asking this is special question. And any illicit drugs or recreational drugs?
No.
Okay. So do you have any family history of the same condition?
Hemoptysis, you mean?
Yes.
No.
Any family history of any lung disease?
No.
Okay. Any diseases rank in your family?
I'm adopted, so I don't know.
Okay. So yeah. Are you married or have a partner?
I have a child. She's 15.
Okay. You are married now?
Yes, I am.
Okay. And uh, sorry for asking this. Any casual relationship?
Yes.
Okay. And what about this relationship? Protected or not?
Protected, yes.
Okay. So any recent travel history?
No.
Okay. Uh, sorry for asking also this special questions. What about your period? Is it regular?
It is regular but a bit heavy because of my fibroids.
Okay. When was the last cycle?
Last week?
Okay. You are using any child birth pills?
No.
Okay. Birth control pills, sorry. Okay. So what are you doing for living?
I'm a teacher.
Okay. So can I examine you?
Yes, please.
Okay. First, I will general look. Any pallor?
No.
Okay. I will examine the hands.
Looks
Any
fine.
abnormality? Any clubbing? Any pulmonary edema? Any
No.
abnormality, deformities in the hands?
No.
I will check the pulse.
Regular. Good volume. 90 beats per minute.
Okay. Then I will examine the eyes.
Looks normal. No jaundice. No conjunctival pallor. No xanthelasma. No corneal icus.
Okay. I will examine the mouth.
Sorry?
The mouth
Mouth.
examination.
Okay. What are you looking at?
Any central cyanosis, any gingival gum hypertrophy, any the mouth hygiene,
All is fine.
any mouth sores,
All is good. Nothing. Yeah.
the nose, any deformity in the nose, so the
Mm.
nose or
No. No saddle nose. No.
okay. I will examine the neck for any lymph nodes, lymphadenopathy.
No lymphadenopathy. JVB is not raised.
Okay. GBB raised,
Not raised. It's not.
not
It's
raised.
normal.
Okay.
Yeah.
Okay. After that, I will inspect the chest, any deformity, any scars.
No. All is fine.
Okay. I will do chest movement and percussion
2 minutes
uh,
left.
and auscultation.
Examination of the chest and the cardiovascular system of the abdomen is fine. Anything else you'd like to examine?
Lower limb edema.
Pardon?
Any lower limb edema? Any edema?
No lower lymphedema. It was just like I forgot to mention. It's just like a lower midline laparotomy scar for the previous fibroid surgery, and that's it.
Okay. Okay.
No lower lymphedema. Anything in the legs you want to look at?
Any scars, any skin change?
No. Anything else?
Okay. So can I know what's your concern?
I'm just worried about why I'm coughing blood. Is that related to my diabetes? Is it related to my previous miscarriages? I'm not sure.
Okay, I appreciate your concern. So from our discussion and the examination, mostly this may be some of diseases called vasculitis or vasculitis. It is affecting it is multi-system disease, a disease called granulomatous with bullangitis. This may be affecting the lung and causing these symptoms as you have. Okay, so we need to do some investigations, imaging to exclude other diagnoses. Maybe also we suspect also infection in your lung. Okay, so we will do some investigation, and after that we will refer you to a team of doctors to give you the proper management plan.
Okay, time is up. You have any concern other than this, Dr. Inas?
No. Can I quiz him now?
Yes. Examiner question, you can
Okay.
start.
Doctor, could you please present your case?
Okay. So this is Miss Sarah Smith, who's 36 years old, female, present with hemoptysis since 24 hours, 6 times. This was fresh blood with 6. There is also some shortness of breath associated, and there is also recurrent urinary tract infection. Just from the she is diabetic and hypertensive. The diabetes uncontrolled. She has also past history of fibroid, and she done surgery for this. From my examination, there is no abnormality in the chest and heart examination and abdominal examination, except there is a scar, midline laboratory scar, and I can't find any positive finding in my examination. Okay. So this is my finding.
Okay. So what is your differential diagnosis for a 1-day history of hemoptysis? Common is common.
Okay, first thing maybe pulmonary embolism. I can put pulmonary embolism, but against that I can't. There is not severe chest pain, no palpitation.
Okay, PE. What other differential apart from PE?
Okay, I will put also vasculitis, but it is more chronic disease, like a glomerulomatous bullangitis or Woodbuster or
yeah. Well, then what is the third differential here?
Sorry.
What is a third differential?
Sometimes cardiac disease like mitral stenosis can cause this hemoptysis, bronchiectasis, cystic fibrosis. All these can cause hemoptysis.
But the
TB,
patient clinical exam was normal in terms of the respiratory, so these are unlikely here.
Yes, the most likely maybe pulmonary embolism, but no risk factors for that.
Okay. The patient has had 8 miscarriages in the past. Would that add anything to your differential diagnosis?
Yes, it will be the first antiphospholipid syndrome, maybe antiphospholipid syndrome causing pulmonary embolism.
Okay. What other hypercoagulable status that could be present in this 36-year-old lady?
protein C and S deficiency, antithrombin 3 deficiency, factor V Leiden deficient disease, and antiphospholipid syndrome.
So it could be acquired or could be congenital or
Yes.
inherited. Everything that you mentioned on the congenital, apart from antiphospholipid, what are other acquired causes of hypercoagulable status? You did ask about the bell,
Yes, I asked.
hormonal therapy,
Yes, I asked.
pregnancy. Well done.
I said shall control birth bills. Yes.
Yeah, what other causes of acquired hypercoagulable status?
Pregnancy also. Pregnancy.
Exactly. Pregnancy is
Mm.
one. Second
Mm.
one is bell, contraception bell, postpartum. If she
Immobilization also.
immobilization, exactly. Recent flights, recent surgeries, paroxysmal nocturnal hematuria, where the patient has had hypercoagulable status and in the morning they wake up with blood in the urine. So you just need to think of could that be PE or not? And what is the risk factor in this lady that makes her predisposed to PE? Okay, this lady has been investigated or is being investigated for antiphospholipid syndrome. Okay, and
Mm.
in terms of her diabetic control, she did have diabetic retinopathy and diabetic nephropathy as well.
Mm.
Diabetic nephropathy in itself can cause nephrotic syndrome, and that nephrotic
Mm.
syndrome is a hypercoagulable status where this patient may present with PE as well.
Yes, that's right.
There are two risk factors in this lady. One of them is
Mm.
the eight miscarriages, antiphospholipid syndrome, acquired thrombophilia, or it could be her diabetes causing nephrotic syndrome causing excuse me, causing hypercoagulable status, causing the PE. If we thinking that it is PE, this is one differential. The other differential
Mm.
is vasculitis, and it's very, very good that you ask all of the vasculitic kind of screen, and none of it was positive. And you look to the saddle shaped nose. So it was just the hemoptysis. So if you're not really sure it's the diagnosis, do not commit to it when you explain to the patient. You will be always safe to say there are few possibilities here. It's most likely it could be a PE, or at this stage, I'd like to do some further investigations and I'd like to rule a pulmonary embolism. Because, particularly, just 1 day history. If it's more of a
Yes,
chronic
that's right.
history, you think of vasculitic, you think of malignancy, you'd be thinking of bleeding disorder. Okay, now thinking that this patient has PE, okay,
Mm.
what investigation you'd like to do for this lady?
Apart from the basic investigation in the form of a complete blood count, liver function test, renal function test, inflammatory markers, and electrolytes, I will do first X-ray, okay, and the ECG and CT pulmonary angiography.
Okay, would you
Okay,
do anything
and
before the CTPA?
sorry.
Would you do any further investigation before a CTPA, or you'll go directly to CTPA?
No, I will do D-dimer. D-dimer.
Exactly. Okay.
Yes. After that, I will do also ABG. ABG also.
Okay.
Okay.
Yeah.
We can do also Doppler ultrasound of the leg veins,
Okay.
cardiac enzymes also, troponin.
Troponin.
Mm.
Why do you want to do trop in this lady?
And pulmonary embolism may be raised in sometimes, and also to exclude the coronary artery disease.
But she has
I
had
mean,
no chest
MI.
pain. She has had no chest pain. I would
Yeah.
only send trop only if she has had any ECG changes. Otherwise, you're just gonna trap yourself with that drop that you are unable to explain if it was mildly raised. Okay, are you aware of any scoring criteria if the patient is suspected to have PE?
Yes, will the score?
Wills score, okay?
Yeah.
And is
Yes.
there any indication where you really do not really need to do a D-dimer and you move straight away to CTPA in these cases?
Sorry, I don't understand the question.
According to Wills criteria, do you always need to do a D-dimer or you can go straight away to CTPA?
No, if there is signs of DVT or heart rate is just tachycardia more than 100, or there is previous pulmonary embolism or DVT, we will go directly to CT angio.
CTPA. If the score of the Wills score more than 4 and above, sometimes you do not really need to do D-dimer. You can move straight away to CTPA. Okay, if I've told you this lady, I know that I said last period was a week ago. If I said that this lady may be pregnant 12 weeks ago, would you still consider CTPA or you would consider an alternative test?
No, scan. I forget the name actually. V scan or
VQ
Q
scan.
scan. VQ scan. Yes.
Yeah, the alternative one is VQ scan. You counsel the patients about the benefit and the risks of both of them. CTPA is risky for the mom, particularly for the breast tissue and risk of breast cancer in the future. Otherwise, well, at least here, wherever I work, they counsel the mom about the risk of about a breast cancer, and they go for CTPA, and they put a shield. But otherwise, you can consider VQ scan if the hospital has facility to do VQ scan. Okay, thinking that this lady has a PE, how would you manage this lady?
Firstly, I will admit the patient. Okay, and I will involve a team of doctors, multidisciplinary team. And
Sorry,
after that, I will do.
What team? Sorry, you want to involve?
Yes, I will pulmonologist and also ICU specialist. Okay, and after that, I will if there is massive or the patient unstable, we can do thrombolysis by alteplase during ICU care. Okay.
What is the indication of thrombolysis in patients with PE?
If the embolism is massive and there's hypotension and there's instability. Okay, instability.
The patient's blood pressure is fine. There's no signs of shock or instability, and there is no indication that she has had a massive PE. Would you still think of thrombolysis here?
No, I will start anticoagulation with low molecular weight of heparin or direct oral anticoagulation like Exiban or rifaxiban.
Is it good to give patients with suspected or confirmed antiphospholipid syndrome DUAC or apixaban, or would rather give them warfarin?
If antiphospholipid syndrome,
yeah,
I think no direct oral anticoagulation.
Direct oral anticoagulation. Okay.
Yes.
Okay. I think that completes my. Okay. If you're thinking that the patient, for any reason, the patient has contraindications for anticoagulation, what are the alternative options for treating PE?
Surgical operation. I forget the name actually of the surgery, but thrombectomy.
Okay. We could consider IVC filter, we could consider thrombectomy, and we could consider ultrasound distribution.
Filter if this recurrent, but to remove the embolism, we need to do thrombectomy.
Yeah.
Am I right?
You're right. But sometimes they put IVC just to prevent the IVC is actually mainly when you have a DVT and you want to prevent a PE. Yeah. No, you're right. You're right. And the only other thing, if you're thinking of antiphospholipid, you normally give warfarin. You do not really give Duax or Abixibans or anything like that. But well done. That completes my assessment.
Yeah, thank you, Dr. Enas. A good question for Dr. Hani. It's long session of examination. Okay,
I grilled you. I've been grilled today with the same case. I've seen it on the ward.
but it's good for him. He just refreshes the knowledge. Let's now review his skills and the judgment on his performance.
Yeah.
So the physical examination, did he examine everything appropriately?
Yeah, I think he was thorough. He wanted to examine. He looked for signs of DVT. He examined the cardiovascular system.
Perfect.
He looked for signs that may suggest malignancy. That's the cause of underlying. Yeah.
Okay. Perfect. So for the physical examination will be satisfactory. I
Yeah.
agree. They identify the signs and the skill. Did he identify the signs or was there any signs to be identified?
No,
Okay.
the patient has had no signs, but he kept vigilant eye on what could be there. He kept an eye for any signs of vasculitis. He kept an eye for any signs of DVT. So
Perfect.
he actively looked at them. Yeah.
Perfect. So again, satisfactory. What about the clinical communication?
Yeah, I think it was very good. His history was very, 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 very thorough. I
Yeah,
think
so
he took 10 minutes and 40 seconds to complete the history.
exactly. Yeah,
Yeah.
I agree. His approach was perfect. That's why he covered most of the things apart from the female history, Dr. Hani. Female history, whenever you are managing or you are taking history from female in this age, 3 Ps are mandatory. Periods,
Yes. I
pregnancy,
forget the portion. Yes.
and miscarriage if you suspect clotting. Plus the birth control, which you ask already. Birth control, period, pregnancy. Pregnancy also, you can ask it as a question. Are you pregnant by any chance? Okay. Plus the miscarriage, very important. Don't wait for the patient or the surrogate to tell you, I had miscarriage. In
Yes.
particular,
That's right.
scenarios with pulmonary embolism or thrombosis. Perfect. Then, so again, the clinical communication was perfect, satisfactory for me. The next will be the differential.
Um, I think he gave me a very sensible differential. Yeah, he gave me PE, he gave me vasculitis. It was really good that he did not put a lot of attention to malignancy, particularly at this age. I've just added to him, and he made sure that he asked about Bill's pregnancy,
Yeah,
if he could just put them in his differential as well as causes of the hypercoagulable status, and to link diabetes maybe to this context may be helpful.
okay, perfect. So again, it's for me also it was good since the role differential. Let's go to the clinical judgment. Did he manage and investigate appropriately? Anything missed during the investigation?
Uh, I think he gave me sensible blood
Management.
test, and he asked for a D-dimer. He could have asked for a pregnancy test if he wanted, and he advised for a CTPA. He knew the Wills score. I think
Perfect.
he knew what he's doing, so I think I
Yeah.
would give him satisfactory. Yeah.
Yeah, by the way, we just discussed this topic last week. He was the one volunteer to give the case, and I think Dr. Ahmed Mansour was the next or the second candidate. Also, he gave him approximately similar case.
No, it
What
was DVT. It was
DVT
DVT.
exactly? Yeah, it was
Yes.
DVT. Yeah. Okay. The concern, Dr. Hani, I have comment on the concern. Dr. Inas first comment, then I will comment. What about concern, Dr. Inas?
Concerns
Yeah,
about
did he manage the concern?
uh Not clearly, I would say. I
Yes.
ask if this linked to my miscarriages.
Perfect.
Yeah.
Not only that, I want to add, you don't have any evidence of this diagnosis now, right?
Oh, yes, yes, yes. Sorry, I have something to say here. And
Yes,
I
I
think
agree.
I got
Okay.
trapped. I got trapped in my exam and I said, oh, this
Okay.
is multiple myeloma. And now I'm thinking about it, I saw how silly I've done that. They do so many investigations to confirm
Yes.
multiple myeloma. And now I'm saying that it is multiple myeloma from a 10-minute consultation. And you cannot really label a patient with specific vasculitis after just taking history. Like,
Yeah,
I would just say it could be multiple possibilities here. It could be
exactly.
most likely here. I'm not sure. I just need to do some investigations.
Yeah. And it's not shameful to say that. It's okay to say that because you don't have clear evidence. So whenever you are not sure, don't say I suspect vasculitis to the patient. You might scare the patient. What is this, doctor? It sound like something serious? I don't understand what you are saying. It's not necessary to give unless you have evidence. Till now, you don't have evidence. It's only UTI, which can happen for any female and because of pregnancy or because of frequency or whatever the reason, or stones, but it's not related directly to the diagnosis. So don't
Yeah.
give her the vasculitis as a clear. You can tell her, I had a lot of possibility. I'm not sure which one you have. However, we are running, or we are going to run some blood tests and work up imaging, and we will be back with you. Okay, that's
Yes,
it.
yes. This is. I think this is the right way to address a
Exactly.
concern. If one can't make diagnosis until he
Exactly.
reaches patient. Yes, yes.
Yeah. So be diplomatic. Don't give a clear, which is wrongly diagnosed. Maybe this is wrong diagnosis, and you are not sure. As I said,
Yeah.
till the end of the scenario, you are not sure what about the case or what could be the diagnosis. So give here, and the evidence. Imagine you give to the patient that you have vasculitis, and the first differential to the examiner PE. So why you didn't tell her PE, and you are telling me pulmonary embolism? It's
Yes, sir.
yeah. It sounds
This
like
happened because after when I am talking to the examiner, I maybe collect the data and after that give. When I collected the data, when he present your finding, I formed a diagnosis.
yes, but still vasculitis as the case for to be explained to the surrogate. It's not clear with no evidence, and it's I think too much or advanced one to be managed or to be mentioned without investigation. Again, unless you have skin rash, musculoskeletal affection, but you don't have any of them, so I cannot say this is vasculitis. I think I'm done with the comment in the judgment, but I have comment on the troponin, Dr. Inas. Troponin, you can do it in the pulmonary embolism, and it's indirectly related. It can give you a clue if there is right side heart strain, and it's one of the prognostic factors and risk to say this patient is having major PE or just mild PE. Okay, so you can add it to your investigation. Troponin not
Okay.
only for chest, for the cardiac, no.
Okay.
For pulmonary embolism can be complicated, or if you have a significant high elevated troponin, the mortality rate might be higher.
Yeah, you're right. Yeah. Yeah.
Okay.
Yeah.
Yeah, the CTPA, there is option to do it with the pregnancy if you can put a shield.
Shield.
It's
Yeah.
not, yeah, so abdomen shield to cover the baby, you can do it. No need to go for VQ mismatch. You can say, as you said, you can give the option to the patient, and the patient will choose. Both of them are teratogenic, by the way. Both of them can affect the baby, the VQ mismatch and the CTPA. But the CTPA, you can cover the baby with a shield, but for the VQ mismatch, no protection. Okay.
Yeah.
Yes. Otherwise, the examination and the discussion was perfect. Well done, Dr. Hani. Any question, Dr. Hinas or Dr. Hani?
No, thank you very much.
Actually, I missed something important. Actually,
What was
in the social, I didn't complete the social history. Smoking, alcohol.
smoking alcohol? You
Uh,
didn't?
Yes, because I see that the time is running.
Okay,
So just
when
I asked it about the job only.
yes, I remember the job, but I'm not. I didn't remember that you asked. Okay, so it might affect your clinical communication, maybe borderline, because it's very important. What do you think the importance of this?
Yes, it is a risk factor, smoking and alcohol.
Perfect. Perfect.
Um,
Yes, you're right. So it's related, maybe indirectly, but still there is a relation to the pulmonary embolism or the clotting, smoking itself. Okay, and yeah, you can add it to the acquired cause of pulmonary embolism, as Dr. Inas mentioned. So you have acquired and you have inherited causes. Okay, you can say both, all of the inherited, as like Dr. Inas mentioned, the paroxysmal nocturnal hemoglobinuria, factor Leiden, and the antithrombin deficiency, factor S, factor C, and also Behcet. You can mention it one of the inherited causes. The acquired, you can add also to the causes Dr. Inas mentioned, the drug or the illicit drug. Okay, Dr. Inas, you mentioned the pregnancy. You mentioned also the diabetes, acquired nephrotic syndrome. You can
OCP,
sorry,
oral contraceptive pill.
yeah, or it's of course one of the important. You have to mention the hormonal oral contraceptive pills, and you can add also the drug, illicit drug. Okay, so you can add the cocaine can cause these medication, these thrombosis. Okay.
Yeah.
Any question
so
else?
yes, Dr.
Yeah.
Inas, I sent the case in the chat box. You can
Oh,
prepare.
thanks.
Okay.
Okay. Perfect.
Dr. Inas, when there is, she said no chest pain, I become confused actually. I first I didn't put pulmonary embolism as a first diagnosis because there is no chest pain, no palpitation, no severe shortness of breath like that. Just most presenting finding is hemoptysis. It is
Perfect.
confusing me.
I have
Yes.
an answer for this.
Hmm?
The complaint was hemoptysis and shortness of breath for the last 24 hours. And I
Hmm.
remember in the last couple of months, I've seen two PEs who presented very differently to the classic PE. One of them was a 96-year-old lady who was doing Pilates and collapsed. And when she came into A&E, the triage in A&E did drops, D-dimer, and all bloods, and her D-dimer came back as 6.6. So the normal is 0.5,
Yes. Exactly.
and she has had 6.6.
So, sorry, how much? How much?
The normal
6.6
is and the normal is 0.5. لسه نص بس. She has had 6.6. And
ah,
they've done a CTPE PA. She has had two sudden PEs, and she actually
Mhm.
died at the end. And she was playing Pilates when she collapsed, and she was not completely fit and healthy, but fit enough to do Pilates at the age of 96.
Oh my God.
And another lady I've seen today, she just had hemoptysis and she has had a PE. Just hemoptysis and shortness of breath.
yes, yes, it is.
Exactly. So it's
So,
not necessary to have chest
mm,
pain. You might have short of
yes,
breath without chest pain.
yes.
Okay.
So,
What?
we usually search for the classic presentation.
No, no, no. In exam, just do your approach. Try to pick up what the possible finding, what the possible differential, and mention it to the examiner. They don't want to give a clear diagnosis. Nowadays, they are looking for the good differential and sensible differential. By the way, I want to add also to the acquired cause, the vaccination, like COVID vaccine. It's very important, and it came before as a rare case, but it's not common one. So the history was about pulmonary embolism, and the patient gave history of vaccine or COVID vaccine recently, and it was complicated by pulmonary embolism. Okay, just put it in your mind if you couldn't find a clear reason of the pulmonary embolism.
So here, Dr. Qasim, when I will arrange my differential, I will firstly put the pulmonary embolism. After that, I will put vasculitis, and after that, what I put TB or malignancy or what?
She mentioned the nephrotic syndrome as a cause of losing protein. Okay, nephropathy with losing protein, so you are losing the protein for necessary for the clotting or for the normal clotting cascade. Whenever you lose this protein, you might have also high hypercoagulable state.
Okay, we talking also about the pulmonary embolism?
Yes, you want to give other differential than the pulmonary embolism you want to say. Okay.
Yes.
The good thing you mentioned in the history, the saddle shape change of the nose, so you can rule out the GPA, granulomatous polyangiitis. You can say to the examiner, I can suspect GPA as a cause, but against that, okay, which is wrongly discussed to the patient. You mentioned to the patient GPA. So even if you want to say vasculitis, no need to mention the GPA itself, because vasculitis can come as vasculitis without even GPA. There is vasculitis can cause pulmonary embolism, not necessarily to be GPA. Okay.
Mm.
The other, you want to say TB, but you don't have any contact. You can say, okay, I have suspicion of TB, but the TB will be not as acute one. The acute one mostly pulmonary embolism. Okay, you have acute onset. So again, it's
Yes, I'm talking about the acute causes in
okay.
this case. Any other acute
Trauma. You
cause?
can say trauma.
Yes, trauma. Yes, trauma.
Okay,
That's
so
right.
yeah, acute
Trauma.
hemoptysis. You can put trauma. You can put
Or
pulmonary embolism.
infections.
Infection. Perfect. Yes,
Yes.
infection.
Mm,
Okay.
mm. Yes, that's right.
Okay, thank you, Dr. Hani. Your case, Dr. Inas. Mr. Atif Kamal, 55 years old, complain of back pain, blood pressure 140/90, pulse 100, temperature 38. Whenever you're ready, let's know. Any question from other candidates?
I'm ready.
Okay, here you go.
Okay.
Oh, hello. My name is Dr. Lalul. Nice to meet you, Mr. Kamal. Can I confirm that you are 50 years old?
Yes.
Um, I understand that you came in with a back pain. Could you please tell me more about that?
Okay. Actually, this back pain started since 1 month and increasing with time.
Okay, so it started 1 month ago. Where exactly is the pain? Where in the back?
In the lower back.
Lower back. Okay. And did it
Yes.
start acutely or more of a chronic presentation? Did it
No,
start
it's
all of a
gradual.
sudden?
No, gradual.
Gradual. And have you been doing any kind of exercises or heavy lifting that may have contributed to that pain, you think?
You mean I lift heavy object? No.
Yes.
Sometimes, actually, I lift heavy objects. But I didn't notice that this followed by this, يعني, by lifting heavy objects.
Okay. And is it there the whole time or on and off?
No. Now it is all the time.
All the time. Okay. Is it better during the morning or the evening?
More at evening. Yes.
Okay. Does it wake you up in the middle of the night because of the back pain?
Sometimes I can't start the sleep because of this.
Sometimes you cannot start sleep. Okay. And what have you tried to help with the pain?
Yes, I try to take painkillers, and sometimes it is improve.
What painkillers have you been taking?
Paracetamol.
Paracetamol. And
And
paracetamol
also,
does
I visited my GP, and he gave me it is Voltaren.
Voltaren.
Yes,
And you feel it's helping.
yes, helped me.
Okay.
Some
How do you score it out of 10? If 10 is the worst
6,
pain ever and 0 is no pain.
6.
6 out of 10. This is with
Yes,
analgesia or with pain relief or without?
No, without
Without.
oranges, yes.
And does it go anywhere? Does it go to your buttock? Does it go to your legs?
No.
And is it associated with any other symptoms?
Like what?
Any weakness in your legs?
No.
Any problems in the sensation or numbness or tingling sensation of your legs?
No.
And excuse me for the question, but when you wipe the area down below, do you still feel it?
Sorry, I don't understand this question.
When you wipe the area, when you go to the toilet and wipe the area down below, do you still feel the normal sensation or you lost sensation in the private area?
Actually, it is relieved by movement.
Okay.
When I move and with my daily activities, it is relieved something.
Okay. So you've had the pain in the lower back for the last month, and it gets worse towards the evening, but it had exercise or movement help it. But did you
Yes.
notice any loss of sensation?
No.
Any problem with the bladder or with moving bowels?
No.
Okay. Any positions that makes it worse?
Yes, when I bend forward or on the side, I feel this pain increase.
Okay. And how is that affecting your life overall?
Yes, affecting my life, disturbing my life and work. Yes,
And what do you do for a living?
I am a farmer.
And a farmer. Okay. And it's affecting your life. Okay. Sorry to hear that.
Yes,
Okay. And did you notice any stiffness in the back at all?
yes,
Okay. And
especially in the morning.
And how long does the stiffness last?
For 1 hour.
For 1 hour. Okay. And did you
Yes.
notice any stiffness in any of the other joints?
No, but there's pain in my joints actually. Other
Which
joints,
joints?
all joints and
All
muscles
joints.
also.
And the muscles as well. Okay. In
Yes.
terms of the joints, did it affect the joints in the hands or the knees or the foot?
All joints,
All joints. And did you notice any swelling in these joints?
no swelling.
No swelling. Okay. So you've had stiffness in the morning, gets better after 1 hour. Exercise help it. Okay. And I'd like to ask you a few other questions, if that's okay.
Okay.
Did you notice any skin rashes or any skin changes?
No.
Did you notice any pain in the bottom of your feet, in the soles?
No.
Okay. Did you have any problems with your bowels? Any loose stool?
No.
Any diarrhea?
No.
Any blood with the stool?
No.
Any tummy pain?
No.
Okay. Now I'd like you to ask a few other questions. Have you had any fevers or temperatures?
You mean high body temperature? Yes. I feel that. But is the strange thing? It is go and come, go and come. I
Comes
don't
and
know.
goes. And did you document the temperature?
Yes, it is. When I visited my GP, it was 38. And one
That
time I checked also in the home, it was 39.
okay. And this been the problem for the last month?
Yes, also, yes. But it is go and come.
Comes and goes. Okay. And
Yes.
what medication do you take to help with the fevers?
Paracetamol.
Paracetamol. Any Rigoring or any chills?
Yes. And at night I become sweaty.
Okay. Any weight loss?
Uh, Actually, I didn't weigh it myself.
And how is your appetite overall?
Decreased.
Decreased. Okay. And did you notice any night sweats?
Yes, I say to you. On the night I become sweaty.
Like, do you have drenching kind of night sweats? Do you wake up
No,
very wet?
No.
Okay. I'd like now to ask you a few other questions. Did you notice any headaches?
Yes.
Tell me more about these headaches.
This come with this high temperature.
Okay. Okay. Did you notice any position that makes it better or worse?
No.
Is it mainly during the morning or the evening or any time of the day?
Associated with this high temperature.
Okay. Are you vomiting anything with it? With these headaches?
No.
No. Any visual changes?
No.
Any shortness of breath?
No.
Any cough?
No.
Any heart racing?
Yes, with high body temperature, I feel my heartbeats fast.
Of course. Of course. Any chest pain?
No.
Any cough or phlegm?
No.
Did you notice any yellowish discoloration of your skin or eyes?
No.
Okay. Okay. Any problem with the waterworks at all? Any
No.
do you go to the toilet to wee more often? Any pain with your wee? Any dribbling with the wee?
No.
Any discharges from the private area?
No.
No. Okay. Okay. You did mention that you've had joint pains. I'd like to touch base on the muscles as well. Did you have any muscle pains or any muscle weakness?
No weakness, doctor. I said just muscle ache.
Muscle aches. Okay. Okay.
Yes.
Okay. And do you have a past medical history at all?
Yes. I'm diabetic since 3 years,
And how do
and
you
I
manage
am
your
on
diabetes?
metformin,
Metformin.
and my diabetes actually controlled. The last HbA1c was 7.
7. Okay, that's good. Are you on any? Do you have any other past medical history that you see your GP regularly for?
Yes, also I am hypertensive since 1 year, and I am on amlodipine 5 milligram.
Okay. Any other chronic illnesses?
No.
Any previous surgeries?
No.
Any medications apart from metformin and the hypertension medications?
Yes, Voltaren and paracetamol for this problem given by
Okay.
by GB.
Okay. And what do you take for your high blood pressure? Sorry.
My blood pressure,
What?
amlodipine,
Um,
amlodipine 5 milligram.
amlodipine. And are you a smoker by any chance?
Yes, I am smoker.
What do you smoke and how often?
Cigarette, maybe 15 cigarettes per day since 15 years.
Okay. And do you drink alcohol?
No.
And you said that you are a farmer, right? And you do some of heavy lifting. Do you take any illicit drugs or any party
No.
drugs? Are you
No.
allergic to
No.
anything?
No.
Okay. Um, what do you think might be going on?
Sorry.
What do you think might be going on?
I must ask you this question.
Of course, I just want to gather your thoughts about what do you think might be the cause for these symptoms before I examine you, and I'll update you what might be the cause.
Okay.
So you have no idea. Okay. Is it all right now to examine you?
Okay.
Thank you. Okay. I'd like to start by examining the hands. I'd be looking for any signs of clubbing, any deformities in the joints, any swelling in the joints. And if any swelling, I'd like to do like full examination, like look, move, and function of the hands.
No abnormal things.
Okay. Now I'd like to move into the face. I'll be looking for any signs of anemia or any signs of
Yes,
jaundice.
there is pallor. There is pallor. No jaundice.
Pallor. Okay. Now I'd like to move into the neck. I'd like to test for any lymphadenopathy in the neck.
Yes, there is lymphadenopathy, cervical, and yes, cervical lymphadenopathy. Yes.
Okay. I'd like to complete my lymphadenopathy lymph node exam. I'd like to test the axilla and
Yes,
the.
you can find also in the axilla.
Okay. And what about the groin?
No.
No. Okay. And then I'd like to have a look if there is any raised GVB.
Hello.
Hello. Is the
Yes. Yes.
JVB raised?
No.
Okay. I'd like now to examine the heart. Any murmurs?
Heart examination is normal.
Okay. I'd like to have a listen to the lung. How's the air entry? Any added sounds?
Okay, chest examination is totally normal.
Okay. Now I would like to examine the spine. I'll be looking for any tenderness throughout the spine.
Yes, there is tenderness
Whereabouts?
in the sacroiliac joint and lumbar spine.
Two
With
minutes
restricted
left.
movement. With restricted movement also.
I'd like to ask the patient to lean to the right and the left, front and back.
Yes, there is restricted movement.
I'd like
Some
to
movement
get the
restriction.
Shabazz test. I'd like to see the distance from the
Negative.
negative. I'd like to examine the occiput to wall distance.
It is normal.
Normal. Okay. I'd like to examine the legs. I'll be looking morely to do a focused neuro exam in the legs, assessing the power.
You mean neurological examination?
Yeah, power and sensation.
No, it is completely, neurological examination is completely normal.
Okay, I'd like to ask the patient to walk as well.
It is normal walking.
Okay, thank you very much. Mr. Atif, what is your main concern here today? What are you most concerned about?
What I have?
Okay, so thank you very much for coming to see me today. From what you've told me and from what my assessment, I am concerned about the back pain that you got. I'd like to admit you and get some bloods and investigations done. And once we get the investigations, I'll come again back to speak to you about what could be the reason, okay? But from what you told me, a 1 month history of back pain that's associated with fever and you've had swollen lymph nodes, I would really need to rule out some sinister causes. I'd like to make sure that it's not an infection that's affecting the back of the spine. It's not really more of a growth that's there, but it's very early to comment on it now. I'd like to take more investigations, do some bloods, do a scan of the lower back, then I'll be ready to update you of what might be the reason. How does that sound to you?
Time is up.
Okay, that's fine. That's fine. Okay.
You have any question, Doctor? Another concern, Dr. Hani? You want to add?
Yes, I have more concerns. Is it serious infection? She said infection. Is it serious infection? And what's the treatment she will give to me? And any advices about this my problem? This is my other concerns. I will ask some questions.
Yes.
So present your positive finding.
This is a 55-year-old gentleman with a background of diabetes and high blood pressure, came in with a 1 month history of lower back pain that was associated with stiffness for more than an hour and improves with mobility. He also reported some night sweats and fevers, and he has a significant smoking past medical history, not smoking. He has significant smoking history as well. On examination, he has had conjunctival pallor. He has had cervical and axillary lymphadenopathy. He has had lower spine tenderness with a restricted movement at the level of the lower spine. A neurological examination and gait were normal. My differential diagnosis for this patient, first of all, I'd like to get a set of observations. And from what you've told me, the patient has had an element, I think, of tachycardia and high fevers. I would be concerned about an infection. I think I'd like to ask the patient about any travel history. I'd like to ask the patient about any high risk behaviors, particularly sex and IVD. I would like to make sure that it's not an infection that's affecting
You
the
asked
lower.
him about that? You
Sorry?
asked him about that? You
No, I
asked him
didn't.
about that?
No, I
Okay.
didn't. So my differential diagnosis for this patient would be um, uh, an abscess in the lower spine or other infections like TB, and it could be as well discitis. He described an inflammatory pattern of the lower back, and that may suggest an element of axial spondyloarthropathy. And the top differential for this would be ankylosing spondylitis. However, on examination, the Schippers test was negative. Other differential for this kind of inflammatory lower back pain pattern would be psoriatic arthritis. However, he did not have any skin changes or any skin rashes. And my other differential diagnosis for this would be enteropathy related spondyloarthropathy, but he did not report any abdominal kind of symptoms. My third differential diagnosis would be an element of a musculoskeletal kind of pain. However, what's against it is the fevers and the significant spinal tenderness the patient has.
Okay. How can you investigate this patient?
So first of all, I would like to send a set of bloods. I'd like to send a full blood count. I'll be looking for any signs of anemia, any raised inflammatory markers. I'd like to send ESR and CRP, looking for any signs of infection or raised inflammatory markers. I'd like to send a bone profile, a liver profile, and UNEs as well. I would like to start with a scan.
So if this patient suspected, this patient is farmer coming with back pain and fever, is this not, you can't suspect anything special? Suspicious?
I would like to send a blood culture. I'd like to make sure that the patient is not septic. I'd like to ensure the patient has...
Which infection you suspect?
So it could be a spinal abscess, it could be tuberculosis, it could be like discitis.
Okay, if we suspect it is brucellosis, it is in farmer, come contact in cattle and sheep, like that. So if we suspect it is brucellosis, how you will investigate or confirm this diagnosis?
So brucellosis is a valid differential diagnosis here, particularly he's a farmer. I would like to send the basic bloods, and I would expect the LFTs to be deranged here. And I would like to discuss with my infectious disease colleagues, to advise on what further investigation needs to be done here. And I'd like to...
So how you will treat him if he have brucellosis?
Okay. So first of all, I would like to stabilize the patient. If the patient came in, we're using my ET approach. I'd like to give the patient some pain relief, and given the significant pain, I'd like to give him some codeine or morphine, and make sure that I give them laxative alongside that. I would like to, after sending the blood cultures and a urine culture, I'd like to discuss it with my infectious disease colleagues, and check the trust guidelines on antibiotics, to make sure that I'm covering for the potential differential diagnosis, like in terms of abscess or brucellosis or discitis. I would just love to take the opinion of my infectious colleagues about what's the best antibiotics till we get a confirmed diagnosis.
Okay, thank you.
Okay,
well done, trainers.
You can comment.
Okay. So, firstly, I will comment about the analysis of the complaint. It will take long time to train us for analyzing the chief complaint. And you was repeating everything, repeating more. Every time you repeat the positive data. No need to do like that with the patient. Okay, every time, so you started back pains in 1 month, increase was improve with movement, and decrease was restless. You recap what the patient say. No need for that. This will consume the time with you. Okay. Just in analyzing of fever, a complaint of fever, what we need to ask is, okay, since when this fever started, is it the first time? Is it a high grade or low grade? Did you check by thermometer? Is continuous or intermittent? Did you notice any relief or increase or like that medication relief? any diurnal variation, like that. Only. So this will take maybe 30 seconds. Okay. After that, you need to ask the associated symptoms, like rigors, body ache, headache, and after that, you need to ask the other general symptoms. Okay, that's enough. This will take maybe 1 minute. You took in this in analyzing maybe 4 minutes and a half. Okay. After that, you missed something about the systemic review. I think you missed family history. You missed travel history. You missed the sexual history. Okay. And the risk factors like high risk. I forget the risk word. High risk behaviors, yes, like tattooing, piercing, sharing, needle shearing, blood transfusion, all this needed to any fever, any case of fever. You must travel history and sexual history and high risk behaviors. You need to ask, okay? About also social history, ask it. You ask it. Yes. Good, but the social history here in the job, when he said farmer, ask him more question about his job. You are dealing directly with the cattle, sheep, and goats, and like that. You wear gloves when you deal with it. You are drinking raw milks or unpasteurized milk or like that. All this positive with this issue. If you ask, no, I don't wear gloves, doctor. No need for wearing gloves. You are drinking, yes, I am drinking unpasteurized milk, yes. So it is positive in this vision. Okay. Also, what you missed also in the history. Yes, this is also about this. This is about history. About examination, yes, you must to do abdominal examination because in this case there is mild hepatosplenomegaly. Yes, lymphadenopathy. When you find lymphadenopathy, you must examine the abdomen.
Yes, you're right.
Okay. It is good that you are examined, but if I feel the neurological examination here not needed, except the patient said there is weakness or there is numbness or there is any change in sensation or any neurological deficit. He said in the history, you can examine. Just maybe you can examine the back. Firstly is the back. After general examination, you will directly to go to the back, examine the back for any terminal local tenderness or like that. Okay. Okay. This is about the examination. The positive here, you will find the pallor, you will find mild lymphadenopathy, you will mild hepatosplenomegaly, and tenderness in the sacroiliac joint and in the lumbar spine. And restricted movement. This is the only positive finding in this patient. Okay. About the patient concern, if you manage it, it is gentle, like Dr. Basil said before, diplomatic. Okay. So in this patient, if I catch the diagnosis, I can say when the patient, what I have, doctor. Yes, I highlight your concern, and from our discussion examination, most you have a medical condition called brucellosis. Do you ever heard about that? No. Brucellosis is an infection caused by bacteria or germ called brucella. This bacteria usually live in animals like cows, goats, sheep. Okay. People can get infected if they drink raw milk or unpasteurized milk, or cheese, or if they come in contact with infected animals. The bacteria can spread after that in your blood and affect different parts of your body and cause symptoms as you have. Okay. Is it serious, doctor? He will ask you another concern. Is it serious infection? Yes, if not treated, I'm sorry to say it is serious condition and may cause serious complications. How can you help me? Yes, treatment is available. It's treatable. Will be in the form of antibiotics for several weeks, and you need to be compliant to the medication with regular follow-up in the clinic. So, any advices you can give me, doctor, about this to not happen again? Yeah, it is the patient will feel here. Yes, to avoid raw milk, wash your hands after handling animals, and try to protective gloves when you deal with animals. Okay, and vaccination of the animals, livestock. Okay, there is vaccination for the animals. Okay, about against brucella. Okay, about the differential diagnosis, the first differential diagnosis is farmer with history of back pain. It is inflammatory back pain. Okay, and fever, and history of drinking raw milk or directly in contact with. This is the first. Will be brucellosis. The first differential will be brucellosis until you prove otherwise. The second will be Bot's disease or spinal tuberculosis. After that, you can put discitis, as you said, vertebral osteomyelitis, epidural abscess, as you said, okay, typhoid fever. After that, you can put ankylosing spondylitis, multiple myeloma. You say against that. Okay. Investigation to confirm or investigation in this patient, we will do the basics. We can find in the complete blood count or full blood count, we can find leukopenia, thrombocytopenia, anemia. And in the liver function, you can find mild elevation in the liver enzymes STL and LD and ALB also. Investigation to confirm brucellosis, blood culture is a gold standard. Blood culture is a concept. But it may take 1 to 2 weeks. Okay. And also we can do PCR and the standard agglutination test. Okay, to detect the antibodies, and ELISA to detect the IgM and IgG. And you will do investigation to exclude the differentials, and also to detect any complications like urine analysis, X-ray, spine, MRI, abdominal ultrasound. Okay. How can you treat this patient? As you said, it's a multidisciplinary team approach, non-pharmacological, patient education and counseling, giving advices to the patient about his job and the prevention of the future, like pasteurization milk and avoid raw milk. Okay, wearing protective measures during work, vaccination of livestock and sheep. Okay, and follow up in the clinic. Sufficient diet and hydration, physiotherapy, and psychological support. Pharmacological, it will be antibiotics. Antibiotics here will give doxycycline, 100 milligram BD for 6 weeks. Doxycycline, 100 milligram BD for 6 weeks, plus rifampicin 600 to 900 once for 6 weeks also. This is the first choice. The second choice, you give doxycycline in the same dose and with streptomycin 1 gram intramuscular injection for 2 to 3 weeks, once daily. So the choices will be doxycycline plus rifampicin. The second choice will be doxycycline plus streptomycin. If the case is complicated, you will give the triple therapy, doxycycline, rifampicin, streptomycin, for 1 year or more. For 1 year or more. If the case is complicated. After that, symptomatic treatment like antipyretics, analgesics. When you say in complicated cases, I will give doxycycline, rifampicin, streptomycin. He directly will ask you what is the complication you know about for brucellosis. So the most common complication of brucellosis is the osteoarticular complications. It will be cause sacroiliitis, spondylitis, discitis, arthritis. Okay, and neurological complications can cause meningitis, meningoencephalitis, brain abscess. Okay, myelitis, cranial nerve palsy, and the most common cranial nerve affected here, Doctora, it is the eighth cranial nerve. It is causing hearing loss. Okay. Cardiovascular complications, and it is the cause of high mortality in patients with brucellosis is infective endocarditis and heart failure. And genitourinary complications like epididymitis and prostatitis, infertility, and liver complications can cause hepatitis and liver abscess. I will share this on the group about these questions or the answers about this question. I will share on the group to revise it. This is my comment.
Okay, thank you, Dr. Hani. Good preparation to the topic. Now you can judge on the skills, please. Physical examination, of course, she will be marked down because she didn't examine the abdomen, right? However, she examined the lymph node, but still the spleen is mandatory here. So I can say the skills will be minus because of linked skills. Because she couldn't pick up the diagnosis, so she missed the physical examination. She missed the investigation, direct investigation, I want to say, clinical judgment, as well as the differential diagnosis. All of them will be affected as a mark, right? Let's go back to the identify the signs. Did she get the all findings? Again, it will be minus, right? Because she didn't find the splenomegaly.
Yes.
Okay. The next clinical communication. I think also she missed some of the history.
Family and travel and sexual.
Yes, HIV risk factor. So again, borderline, Dr. Ines. And then a differential also was lacking of the diagnosis itself. Whenever you have brucellosis, Dr. Ines, in PACES, think about our case today. Sorry, the back pain. Okay. So spinal arthropathy. Whenever you have brucellosis in PACES, think about spinal arthropathy or back pain as a complaint, as well as infective endocarditis. You can find it also in the history or in the PACES. Okay, it's very important. Two topics related to brucellosis. Lymphadenitis, splenomegaly, as a vague presentation also. It can be as a differential. You can put lymph node or lymphadenitis, you can put brucellosis, in particular, farmer. Then the splenomegaly itself, you can put it as a differential. Okay, so farmer and PACES, these three presentation: back pain, infective endocarditis, as well as splenomegaly. Put it as a differential whenever you have farmer. Okay. Let's go back to the differential diagnosis borderline, and because you didn't mention the diagnosis itself, clinical judgment as well. It will be again is as linked skills. So borderline because you couldn't catch the case, you couldn't give the differential specific investigation for the diagnosis. Concern managed well, satisfactory, right, Dr. Hani? Any change?
No, no.
And the welfare
Welfare is satisfactory.
maintained.
Mm.
But the good thing Dr. Ines did while giving the differential diagnosis, she said to the examiner, I would like to say the causes of inflammatory back pain. And she gave a lot of them, like ankylosing, like psoriatic. However, she didn't or she missed the brucellosis as a cause. But it's very important to say what the type of back pain you have. And you can find it from one question. I can say this is the most important question. I can say it as magic question of back pain. Whenever you have back pain as a presentation, ask the patient what is or what can make this pain better, the movement or the wrist. Whenever you have the wrist improving the pain, this is mechanical back pain. Whenever you have the pain is worsening with the wrist and improving with the movement, this is inflammatory back pain. I think it's clear to all of you. You have to ask this question. It's one of the mandatory questions.
But in
If
this
you,
case, I've
yeah,
had two different answers. One
yes,
of them was the pain improves with movement, and one of them, the pain with stiffness more than 1 hour in the morning. And these to me like contradicts what kind of pain was it?
still
Until unless
inflammatory one.
saying anything.
No, no, it's inflammatory back pain.
And the movement should help with the pain.
The hell, yes.
Yeah, but
So
he
the
said movement uh, makes the pain worse. Maybe I'm missing something, I don't know.
he said the movement may make the pain well. Yes.
Well, I thought worse. Okay, that's fine.
No, no,
Yeah,
it improve with the movement. He
yeah.
mentioned. I'm sure about this. But you said also that this is inflammatory one.
Based on the stiffness, I've said.
Ah, okay. So the stiffness usually comes also with the inflammatory. Okay. Any question, Dr. Ines?
No, that it's clear now, yeah.
Okay. Don't forget the Farman empasis. It's very important. You will find it in two scenarios: brucellosis, and the brucellosis will be presented as we mentioned, back pain, infective endocarditis, splenomegaly. Okay. You can also put TB, but TB usually contact with the person or chesty person, and you will have also the travel history, endemic area, plus the chest symptoms, and also you have to pick up this finding is very important. The constitutional symptoms, and it was positive here: loss of weight, night sweat, and appetite as well. It will be impaired. Okay, don't forget the. I think you'll not forget the brucellosis again. Farmer and paces equal to brucellosis. Okay. Yeah. The other thing also related to the farmer, the ABBA, allergic bronchopulmonary aspergillosis. Remember it also. Okay. So you can find both in farmer and paces related to either brucellosis as infection or exposure to the aspergillus, and you will have the patient with ABBA, allergic bronchopulmonary aspergillosis. Any other question, Dr. Inas?
No, thank you very much. That was a good one.
Okay. Dr. Hani, any question?
Thank you. Jazakallah khairan.
Okay. Dr. Henry mentioned in the chat box some jargon by Dr. Inas. I agree it was jargon, but in PACED they accept such words. Okay. Anyway, try to be more simple while talking to the patient. No need to say acute or chronic. Just tell him over day, over months, over hours. No need to be saying as a term. Give it as duration rather than as an onset of uh, term. Okay, acute or chronic. Because anyone he will tell you, doctor, what is the acute and what is the chronic? I don't understand. And even some doctors, if you told him what the difference between acute and subacute and chronic, some doctors will give you some variable duration. Some doctor will tell you acute within hours, and there is also what we call it hyperacute. So no need to mention the term itself. Give me the duration. Is it hours? Started within days, within months? It's not only for this case, for any case. Don't give vague words. Okay, clear, Dr. Ines?
Yes. Thank you very much.
Oh.
Yeah, I got this. Yeah.
Okay. For the previous case, I want to add one important question to Dr. Hani. Whenever you have bleeding in any presentation, hemoptysis, hematuria, bleeding per rectum, bleeding per gum, don't forget to ask any blood thinner medication, especially those with a chronic illness. You didn't ask this question, which is very important. The patient might tell you, yes, doctor, I am on aspirin. You might change the old diagnosis because of a medication. Okay, or I'm on warfarin because of my heart gate. The diagnosis will be
But
totally changed.
I think maybe included in when I ask him your drug list or
I'm not
medication
sure.
list.
No. Please don't assume that the patient will give you the medication in his medication list. Some candidate or some surrogate will hide, even if he will not mention or and he didn't ask. You can put it as one of the differential. The examiner want to like to hear such differential, especially those patient with, or for example, patient with infective endocarditis or metallic valve and he's on medication. Yes, it's not related. Maybe he didn't take the medication. Maybe something happened, but also it might be the reason. It might be the linked differential diagnosis. What I want to say, search about it as a acute cause, okay? Not only acute and directly related cause, okay? Don't assume the patient will give you the medication and his medication list. Sometimes you forgot to see the list. Sometimes you didn't ask, and the medication will be the reason of the same presentation. It's a lesson we are learning about it. Hematuria also comes in phases, by the way. It's very common topic, and I heard a lot of topics in a lot of cases of hematuria in Oman. Oman, they have a lot of nephrology cases, and they like the topic of nephrology disease. So hematuria, one of the presentation they like to bring. If you couldn't ask, if you didn't ask about this question, they might mark you down in the clinical communication. Okay? Just to remind yourself, whenever I have bleeding, I have to ask about blood thinner medication.
Mm.
Yes, Dr. Henry also mentioned she used or she took more than 10 minutes for the history. I think there is some lagging in the internet also make this time longer. Anyway, try to be faster, Dr. Ines. I think you know how about your performance from the first attempt. Whenever you are defective and your skill is affected by the mark, try to improve it in your practice. You can send me even your feedback, and I can focus on the parts you missed or you have mark list.
Oh, thank
Okay?
you. Very helpful. Thank
Yeah,
you.
Miss welcome. Any question from any comments? Anyone want to add any comments?
Thank you very, very much. I found this really helpful.
Most
Thank you.
welcome, Dr. Ines. Anytime, you're welcome. Okay. Thank you, Dr. Ines. Thank you, Dr. Hani, for practicing today. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.